Hello, my name is Peter Hammond. I'm a consultant diabetologist at Harrogate District Hospital, and for this topic I'm going to be talking about the third trimester of pregnancy and the use of steroids during this phase of pregnancy. Here are my disclosures. The learning objectives for this topic are understanding what to expect in the third trimester of pregnancy, understanding what happens to glucose targets during this phase of pregnancy, understanding how the insulin requirements change, and understanding what happens if steroids are given to mature fetal lungs during this stage of pregnancy. So what should you expect in the third trimester? Well, the baby is getting larger, so fetal growth continues throughout the third trimester. And as a result of the increasing restriction within the abdomen, eating becomes more difficult. The baby's getting larger, taking more nutrients, and there's increasing fatigue. And the changes to make delivery easier mean that there are changes to soft tissues which result in muscle joint aches and pains. There's more frequent review to make sure that blood glucose control is on target with 1 to 2 weekly clinic visits. And because of the potential for the baby to grow too much, growth scans are frequent during this phase of the pregnancy, occurring every 2 to 4 weeks. And then towards the end of the third trimester, plans need to be made for how the diabetes will be managed during delivery. And this usually happens at about 36 weeks gestation. Time in range is the same as it is throughout pregnancy. So what you're aiming for is to be in the target range of 3.5 to 7.8 millimoles per litre, and ideally to spend over 70% of time in that range. Each day, the aim is to get just under 17 hours in the target range, but this does mean that you can have about 6 hours above the target range of 7.8 millimoles per litre, although obviously not too much above that. And equally, try to minimise hypoglycemia with less than an hour below 3.5 millimoles per litre and less than 15 minutes below 3.0 millimoles per litre. It's really important to stress that for every 5% increase in time in range, there is a significant reduction in the risk of the baby growing too big or having problems in the neonatal period. During normal pregnancy, insulin resistance increases throughout, and this is a result of changes in other hormones and other factors during the pregnancy. And because of this increase in insulin resistance, particularly during the second half of pregnancy, there is an increasing demand for insulin. So the expectation is that insulin requirements will increase significantly from mid-pregnancy onwards. This slide demonstrates how these changes occur. So you'll see that insulin requirements remain fairly similar up to about 18 weeks gestation. And then particularly from 24 to 32 weeks gestation, there is a marked increase in insulin requirements, which then peaks around 34 to 36 weeks. So the insulin requirement is roughly 0.6 units per kilogram at 16 weeks and goes up to about 1.0 units per kilogram at 34 to 36 weeks, although this is highly variable in terms of the absolute amounts required for the individual person. In late pregnancy, there is a possible small decline in the insulin requirements because there's a reduction in the hormones produced by the placenta, and the fetus is using up more of the glucose from the maternal circulation. However, if there's an excessive fall in requirements, this could be an indication that the placenta is failing. A fall of greater than 50% in the total daily insulin dose is associated with an increased risk of preeclampsia, small for gestational age babies, early delivery, and admission to neonatal intensive care. But it's important to stress that in most cases, even a reduction in total daily insulin dose of greater than 15% will still be associated with a normal outcome. I've already mentioned that in later pregnancy, insulin requirements increase, but there's actually a change in which component of the insulin requirement changes, so that the biggest change in insulin requirement is accounted for by a change in bolus insulin. In early pregnancy, bolus insulin accounts for about 50% of the total daily insulin dose, but by late pregnancy, bolus insulin is accounting for about 65 to 75% of the total daily dose, as we can see on this graph. By contrast, basal insulin changes are relatively small throughout the pregnancy, with the increase in basal insulin requirement about 25 to 50% And again, this varies according to the time of day, as you can see from the graph. However, bolus insulin requirements may increase fourfold, so that if you've got an insulin to carbohydrate ratio in early pregnancy of about 1 unit per 12 grams carbohydrate, by the end of pregnancy you might be needing 1 unit per 3 grams carbohydrate for breakfast and 1 unit per 5 grams carbohydrate for other meals. This shows a bit more about bolus dosing in later pregnancy, because not only does the amount of bolus insulin requirement change, but actually the timing of the bolus becomes critical as well. It may not look particularly marked on this graph, but the peak insulin concentration in later pregnancy occurs about an hour later than in early pregnancy. And this also results in a change in glucose disposal. So in the lower graph, you can see that glucose disposal is slower and occurs over a longer period of time. So because of this, you may need to give the insulin bolus 45 to 60 minutes before the meal in order to get optimal post-meal glucose control. When you come to adjust the bolus ratio in later pregnancy, again, you're aiming for a 1 hour postprandial blood glucose of less than 7.8 millimoles per litre and a rise in glucose after the meal of around 1.5 to 3 millimoles per litre. So if these are exceeded, then you need to change the ratio. The other issue that happens in later pregnancy is that gastric emptying slows, so the nutrients are absorbed over a longer period of time, and for that reason there may be a need to split the bolus insulin dose, or if you're using a pump, to use a dual wave bolus for optimal control of postprandial glucose. The other thing to be aware of in later pregnancy is obviously not only can you change what you're doing with insulin, but actually changes to diet composition can make quite a difference as well. So in these CGM traces, you can see in the top trace there's quite significant swings in glucose levels after the meal. The sensor glucose average is 7.4 millimoles per litre and the average daily carb intake is 190 grams. This person made quite a lot of adjustment on the basis of what she was seeing on the upper trace, and when the subsequent trace, looking at the next 4 weeks, was observed, you can see that the sensor glucose average is now 6.6 millimoles per litre with less insulin requirement, but due to the average daily carbs being reduced to 114 grams. So if postprandial blood glucose control does become a problem in later pregnancy, then changing the type of carbohydrate, the distribution of the carbohydrate, whilst making sure that you're getting enough nutrients can be really helpful. Finally, there are circumstances where steroid treatment might be required during the 3rd trimester. So most centres will give steroids to any woman who is having an elective caesarean section in order to facilitate fetal lung maturation, and they'll also be given where there's a risk of the baby being delivered prematurely by whatever method. Steroids are usually given in 1 or 2 doses, and insulin requirements usually increase by at least 50% from about 6 hours after the first steroid dose. And you can see this on the top graphic, and indeed you can see it on the lower graphic where steroids are given much closer to the time of delivery. So for 24 to 48 hours after the steroids being given, there's a requirement for really close monitoring and insulin dose adjustment. We still try to maintain insulin delivery subcutaneously by increasing either insulin infusion rates on a pump or insulin basal doses by around 50% and making a similar change to the bolus doses. But if the close monitoring shows that blood glucose levels are rising too high despite those changes, then there may be a need to switch to a variable rate insulin infusion. So in summary, what can you expect during the 3rd trimester? You can expect more frequent clinic visits and to start making plans for what happens at the time of delivery. There's an increasing need for insulin, and this is particularly in terms of bolus doses, which may need to change in other ways. But in late pregnancy, there can be a small fall in insulin requirement, but it's important to note that a larger fall may be an indication that the placenta is not functioning properly. Steroids are often needed to help mature fetal lungs before delivery, and in The 24 to 48 hours after steroids are given, there can be quite a significant increase in blood glucose levels, so that close monitoring and frequent insulin adjustments are needed at this time. I hope you've enjoyed this topic. Now you should have a good understanding of what to expect in the third trimester, what happens to glucose targets, how insulin requirements change, and what happens when steroids are given to mature fetal rungs during the third trimester. Many thanks. I hope you've enjoyed this topic and found it useful.